So, 11:03 Uhr. Es kommt noch ein. Sir.
Ladies and gentlemen, dear participants of the Health Innovation Summit 2023 here at the Nordic embassies, dear representatives of the tech and pharmaceutical industry, of the hospitals and the care industry, dear Danish-German Hospital Alliance and the Care Alliance, dear reformists, dear critics, or let's be a little more cheeky, dear revolutionaries, dear disruptors. And so I would also like to welcome those who are feeling the pressure of the current health system. This is making us rather dizzy, isn't it? So it's not easy to cover this subject, to be as comprehensive as possible. This summit or this topic is so important, and it's so difficult to open up this important topic. And it's also going to be difficult to host this event. You might be the judge of that later on at the end of the day. So health really has an impact on all of us. And as a foundation of this society, of this wealthy society, this is very important. Not just planning, innovation, but also communication play a vital role in this area. And the new buzzword here is also management of expectations amongst the citizens and population. Well, communication with regard to the pending reforms of the health sector in Germany and Denmark are very important for both of our countries. This applies to our well-being in general, but it also applies to our wealth, and it also might even apply to the maintenance or preservation of our democracy. So, due to all of these difficulties, our team of health at the Danish embassy asked me to open up, give you the welcoming remark of today's conference. So that's really a rather undesired job, but since I'm the head of communication, I was supposed to kick off the event, and I would just want to give you like a 5-minute speech, maybe like a power bar that you can eat in 5 minutes time, and then we might be done with a welcome remark. So, well, I was wondering how to open up this conference. There are different approaches. I could start with storytelling about Denmark, how well things are working in Denmark despite the pressure of the austerity policy and the lack of skilled workers. Well, you could also talk about the health reform in Denmark. You could talk about the already started centralization and also the outpatient reform in Denmark and the digitization reform in Denmark. So data of patients are supposed to be digitized in the best case scenario in Denmark. Well, I'm taking a different approach here. I myself am originate from social sciences, and since catastrophes go hand in hand, and I've been working as an analyst for decades. Well, or as a journalist actually, but journalists are pretty good at asking dumb and annoying questions, and questions that sometimes even lead to smart answers. That's why I decided to raise some annoying questions as an introduction, because there's one thing that's for sure, that merciless digitization, the economic pressure of reforms, the demographic challenges, and also the lack of skilled workers, which is also affecting medical progress and also climate change and climate crisis, all of that is actually requiring greater speed, greater efficiency with regard to the innovation of the health sector and, of course, also the care sector. So we have to be dealing with annoying questions. So therefore, I would like to put my journalist hat on now, and I would like to raise some questions. As this is a German-Danish format, and would be very interesting to take a look at the differences between those two countries. We have a tax-based prioritization system in Denmark, and we have a lump sum system in Germany. And we have a small country and with large acceptance with regard to the state planning on the one hand, and a very large federated state or country on the other side. So, as I said, here in Germany, we have the principle of federalism. We have the digitization in Denmark versus Germany. Despite efforts with regard to the digital file of patients, we still encounter big obstacles in Germany with regard to digitization. So let me raise that first annoying question. Number one, the challenges in Germany and Denmark are quite similar to each other. In both countries, we have great sources of inspiration. For instance, the Danish-German Hospital Alliance and the Care Alliance was initiated by this embassy. The German Expert Council in Denmark, for instance, I think many of the Danish delegates also traveled to Germany, was launched. And we also have a German-Danish plan of action. But what is a Danish-German cooperation meant to achieve? That would be my first question. Number two, if the care and health sector work together, should they have a more trust-based relationship in order to be more prone to innovation? If you take the outside look here, it might seem schizophrenic if you take a look at Denmark, for instance. In Denmark, there is the aspiration to be the world's best health system. And sometimes it seems that the hospital and care sector seem to however, be in an existential crisis. They announce big budgets and then again they cut it. Well, of course, the root causes with that have to do with the Danish transparency. So you can take a look at the long waiting times in Denmark. All of that is very transparent, and we have a very open and transparent culture of admitting mistakes in the health sector. Despite that, Denmark seems to have more trust in itself, seem to be more confident, and seems to provide more room for reformists and for experts to reform the system. Same applies to Germany, or not really, because Germany has a more skeptical spirit. Sometimes you might even call it a spirit of complaining. It seems to be the national sport here. So maybe it's time to change the storytelling. The third question I would like to raise is stronger political planning and political steering is indispensable. Is that the question? So we have some very unpopular decisions we should make here in Germany. And of course, in Germany, you see many different stakeholders are invited to negotiate the reforms here. But maybe the central political steering of this might be important to foster innovation. Number 4. Well, innovation, that's for sure, yes. But where are we heading to with our health system? Well, we want to be the world's best health system, but according to which requirements? In Denmark, we spend 10% of the GDP for health. In Germany, it's a little more, which is quite telling, isn't it? But regardless of whether we are talking about 10 or 11 or 11.5% of the budget, well, the bottom line here is that we are not spending enough or just too little for prevention. And just recently, I talked to a very smart expert. She's also here. I'm not going to name her. And she was quite provocative. She said, we have ambitious researchers, we have responsible doctors, we have policy makers, and we have profit-oriented industry stakeholders, and they are spending money on people who are already heavily sick and those who have comorbidities or who are dealing with several diagnoses at the same time. Well, for the health of the population, they spent only very little money. They spent more than in Denmark, but that was the critical stance of that expert. And this leads me to that annoying question, where are we headed to? Where do we want to head to? What role is innovation supposed to play? So this results in question number 5. What is actually progress, especially in the care sector? Innovation is quite a broad subject or term. And care, we might be talking about automated systems, navigation systems, systems that protect you from falling, and also emotionalized robotics. So we have a broad spectrum, starting with next generation sequencing up to immune therapies, and in hospitals it's all about AI and patient data, also biosensors, activity trackers, in order to optimize infrastructure, and the list goes on and on. And I could go on for much longer about this issue. But as a non-expert, you don't really know how to judge science fiction from non-science fiction, and you need to communicate that. And all of these industries need to really ask themselves, where do they want to go, or which direction do they want to head to with regard to innovation? My last annoying question: how can we take people's fears away, from digitization and also progress? Of course, in Denmark, this is easier than in Germany, because citizens in Denmark don't consider their state to be a threat, but in Germany, they somehow consider their state to be a threat and not a very trustworthy service provider. Well, we have the EU Commissioner for Competition and Digitization was just recently here. She's from Denmark, so Vesthagen. And she said that in Germany and in many other European countries, people feel quite skeptical towards the state with regard to their health data. And at the very same time, people are just giving their data away to American companies. So to her, that was quite contradictory. Yes, in Germany, we also have a social class that is not a low-income class, but they always have great trust in their state. And here I'm not... I could tell you that in Germany, with regard to the practitioners and the practitioners' offices, telematics and GPs, we really need to build more trust here. We need a greater leap of faith. So, summing up, we want to dare to present innovation. We want to dare to tell our citizens where we want to go. And let's dare to be more self-confident with the narrative that we're actually telling. Well, I don't have all the answers, but it seems to me that these questions are also part of the conversation about innovation and the potential of innovation, which we would like to incorporate during this conference. So if we want to be successful, we have to talk about these questions. So let's just briefly show the agenda. Thank you. Maybe someone can help me here from the technician's side. Thank you. Great. So let's briefly talk about today's agenda. We're going to listen to 2 brief presentations. One presentation from Denmark. Jan Kennen, he's actually in the front row. He's director at FIRS, the Foundation for Life Science Innovation in the region Zeeland, or Zealand, however you want to pronounce it. Next up, Michael Meyer, Secretary General at the German Society for Integrated Care in the Health Sector. So as I said, 2 presentations, and 10 to 12, we are going to divide you or into 3 different workshops. One is dealing with sustainability. Second workshop is the patient journey, which is going to be in English. And the third workshop is going to be about innovation in care, which is going to be in German. So you are going to be distributed here in this embassy. 10 to 12, we're going to put you into your different groups. At 1 p.m., we have a light lunch and networking, of course. Let's not forget about that. That's the reason why we came together. At 2 p.m., we're going to meet again, and we're going to present the results of these 3 workshops. And 3 p.m., so at 3 p.m., we're going to end the conference. Or at least the formal part will be over at 3 p.m. Afterwards, we have a get-together, and which is also an essential part of this process of innovation in general. So that was the agenda. I hope you have a successful and very innovative day today here at the Nordic embassies. Thank you very much to the health team from the Danish embassy. Thank you for putting this event together. You did a great job. Thank you very much for coming here today. Jan, the floor is yours.
Das ist right. So, vielen Dank. Und sehr geehrte.
Thank you very much. Ladies and gentlemen, thank you very much for this very friendly welcome and the invitation to come here. My colleagues in the region of Zealand and myself are happy and proud that we were invited to describe our situation and the solutions that we're working on. My name is Jan Kane. I am the director of the Fund for Future Innovation called FEARS. As I'm going to show you, the region of Zealand is facing grave health challenges. It will be impossible for us to provide a meaningful and sustainable health system to our citizens in the future if we do not come up with radical new solutions. One of the most important solutions for us is to enter into partnerships and to develop innovative approaches that go beyond borders. Denmark, as you know, is a small country, and the region of Zealand is particularly challenging, so it would be naive to believe that we have all of the right answers. So we are looking for solutions everywhere in the world, and particularly this is one of the reasons why I'm so happy to be here today. I'm convinced that by cross-border cooperation, we will be able to create solutions and make offers that will be benefiting our citizens. We are strong together.
Part of my introduction, so I hope you'll bear over with me that I will now give the rest of my presentation in English, and I'll just continue from here, and I hope it will be bit more fluent. But shortly, in Region Zealand, we are on a mission, frankly. We see ourselves as being the one region in the Denmark who will show the rest of the Denmark how they should work within the healthcare sector. And we talk about, what do you call it in German, dansk selvfedme? Yeah, that was an example of that. But we actually do it, we're quite humble in the way that we do it because we are one of the regions in Denmark which has the greatest need for innovation and for new solutions. The challenges that we find, especially in Nykøbing Falster, the smallest acute care hospital in Denmark, where we are based as an innovation unit in the region, The challenges we find here are larger than anywhere else found in Denmark at least, and probably also in a lot of the Nordic countries. We are in the top 5, you could say, or the bottom 5. And the challenges we face, they arise from an interplay, a lot of complex demographic challenges, but also in a small country like Denmark, also from a geographical division between some of the biggest cities, the capital region of Copenhagen, and the rural areas in Denmark. And I think that is also some of the issues that you find and see in Germany as well. So we work for greater equity in health. And the answer we have found so far to how we might succeed somehow with this is through partnerships. And luckily, that is also why I'm here today, is to talk about partnerships and how we work with those. So the answer to a lot of the questions you asked here, my answer would be partnerships, and maybe more partnerships and collaboration. I know today that my presentation, I was really happy this morning. I learned I had 20 minutes and not only 15. So I don't need to speed up because we have a lot to tell you and a lot on our mind. So it will be a bit of a tour de force today, my presentation. But if you remember 3 takeaways from me today, it should be those 3. I've summarized it into 3 main points. We face some great challenges for our welfare system. Healthcare is no exception. We see a development in Denmark, I believe it's the same all over Europe, with more elderly citizens, more citizens with multiple and chronic diseases, and also in our region, especially mental health is also a rising concern, especially for the young people. And we also, and when I made this presentation for today, it was really important for me not to talk down the Danish health system, because it has been one of the best in the world for many years, many decades, and it still is. And I like to see it as a bumblebee, you know, the insect which really shouldn't be able to fly, but it still does. And the Danish healthcare system works in a bit of the similar way today also. Because it was designed, not the bumblebee, but the Danish healthcare system was designed in a different era than we have today. And I think that is a very important point. It works because we have very, very dedicated staff. So that means that we have to find new ways, and we cannot continue to do things the way we used to do. We need to innovate, and we need to find new ways to do the things that we need to do and the progress we need to take together. As at least the Danes here today don't know, there's been a commission in Denmark called robustness in the healthcare sector. And they've just announced some of their recommendations, and fortunately, quite a few of those align with the work we do in the region of Zealand. It might be because one of our main hospital directors, Rico Dyr, has been part of the commission. I hope to think so, at least. Or maybe we learned something from the commission before the recommendation were announced. But the essence, and I won't go through all 20 of them, but the essence of them, the recommendations, they are very, very simple, actually. In Danish it says, ikke alle skal have det samme, which translates very simple into, we are not supposed to offer the same to everyone. We need to look into differentiated care so that we actually achieve the best health outcomes for those who need them, and not one size fits all. And this is of course really interesting, but before I get carried away with our approach into equity in health, I would like to invite you to a small tour in the region of Zealand. before we go to more concrete examples and solutions that we work on at the moment. Today we can see some very clear patterns in the Danish healthcare system. We get more elderly and chronically ill because all of us, as we get elder, it's very simple. We get more sick and we get more illnesses at the same time. Even though we have a very egalitarian country in Denmark, or at least we think so, we have still a very marked social inequity in health in Denmark. Within the healthcare sector, but also in a lot of other public sectors, but especially within the healthcare sector, we have really a large lack of human resources. We miss staff. We are really, really understaffed. And also, I think it's a very important point also that what we will also discuss today is we have a lot of technologies entering the healthcare sector, which is a challenge both for our patients, which we are here for, but also for our staff. How to handle. I heard a story from the municipality of Lolland, which is one of our very close partners in healthcare. They said that their ground staff, they have today to handle 27 different apps on their phone, reporting and managing, just as an example. And finally, not at least, and that might be true both for in Copenhagen, but also in the countryside where we are, we see a new form, a so-called healthcare consumer. People that are no longer prepared to settle for the verdict of just one doctor. They insist on being like, you could call it like co-creating their own sickness. Or at least being really informed in detail also about other solutions, other offers, and so on. And I really see this as a good and positive development, but it also required something very, very different from our healthcare staff. When I mentioned that in Region Zealand and the area around Nykøbing Falster Hospital, we represent one of the most challenged regions in Denmark in terms of healthcare. I usually just use this slide, and I don't need to say so much more, because you see on this one you see the life expectancy in Denmark within the 98 municipalities in Denmark, and the area we cover is here. And the difference between the life expectancy in our area and the best one, I think it's close to Brian from Bispebjerg Hospital, who is also joining us today. It's up here. The difference here is 5 years in life expectancy. Within a small country like Denmark, within the region Zealand, the difference is actually almost 4 years between the best municipality and the worst. So there's still differences. And I could provide you with a large number of different statistics and data on what are the challenges that we face at the moment. It could be average lifespan. It could be something about can you actually get a doctor? Or can you? Is there a patient intake? It could be something about age and number of these disorders. Or it could be something about education and also the number of disorders as well. And the day before yesterday, I learned from a population survey in our area. One of the researchers, she's just going to publish it later this year, is that they found a coherence between conflicts in the family and the bad health of children. So there is a direct connection between those areas as well. So I think that's very, very, very interesting. And at Nykøbing Falster Hospital, we encounter significant challenges on a daily basis, primarily related to 2 key areas. Firstly, there's a shortage of staff, like I mentioned. Just an example, if you look into nurses at the emergency department, at the moment we lack more than 50% of the nurses. we don't lack 50% of our patients. The numbers are still the same, unfortunately. And that really influences the way that work is done at the emergency department. The same, we could look into the composition of citizens in our area. We have, in Lolland municipality I just mentioned, we have 40% of the population suffering from 2 illnesses or more. The population there, they also have 25% of the population there, they are obese, meaning that they have a BMI of over 30, which we already now, but also in time will look into. You could say that we need to provide some different health care services than we do today. Just another example. If you want to look into, see what is actually the root of the problem. Where does it start, this? Is it at the hospital, or should we look into other areas where we can join partnerships and find new solutions? This is showing the intake admission rate at the emergency department over 2 months during this spring. And if you look into the details, I think there's 4 days where we have an admission rate of being just fully booked. For the rest of the days, for those 2 months, we have an average of 170% overbooking, if you can say so. So when we're looking for the cause of the problem, or the problems, you could say, we should be moving beyond silos, in Denmark at least, and also within traditional healthcare, and look at more preventive healthcare solutions. So the question is, I think, what would happen if we started from the citizen and not from the system? If we turned everything on its head. So instead of prioritizing the system, which we tend to do, it's easy and it's very comfortable, and everyone is asking for money within the system, we should try to flip everything on its head and create offers for our citizens, which starts with their actual needs and not how they could fit into an existing system, which was, like I said earlier, created for another area. So, my point is also today that we cannot do this as a regional hospital alone. We can only do that in collaboration with a number of partners, being both civil society, but definitely also private actors and the industry. In Denmark, we say that it's better to make the cake larger than cutting it into thinner slices. And when we look into more players, more people who like to engage in finding sustainable healthcare solutions of the future, this is what we mean when we talk about a holistic healthcare system, is that we join forces. Nikolai framed it earlier yesterday, saying we talk about a coalition of the willing, not of the winning. We might be winning also, but those who actually want to join forces, seeing a common interest in this for all of us, so that we can distribute the little resources we have in a better way. And I think also this could sound like a party tale, giving at a wedding or something, but I think my point is also we don't do this blindfoldedly. We always do. Our approach is based on data, and I just wanted to show you a data platform that we in Region Zealand offer our municipalities and our staff, which is actually a management decision system based on data where you can get. This is an example of the readmission data for the region, or for the region for the last year, which can be used as a decision system for saying, is this an important area for us to prioritize? Is this an area where there's actually a potential for improvement? At last, I would like to offer you 2 examples of some very concrete public-private innovation partnerships that we have engaged in. The first one is AcuCare, which is our signature partnership project with Falck and Roche. The goal of this public-private partnership is to reduce emergency readmissions to hospitals so that citizens with chronic diseases can stay at home, have fewer admissions at the hospital, and get the treatment they need at an earlier stage. So basically, the project's goal is to reduce the burden of the healthcare system and freeing up staff at our place, which can be used out at the citizen's home. So connecting the public and the private partners and offering a proof of concept as well as a business model is the project's core objective. And consequently, this project is focused more on cooperation, collaboration, and new models of healthcare than on technology. Technology is the least worry in this project, I would say. And we also have the pleasure today of having Nikolaj Søndergaard Laugetsen, Head of Innovation from Falck, with us today, and he will provide us with further insights into this partnership project at one of the workshops later on. I mentioned earlier also in my presentation that we also reach out in the world. We strongly believe and we strongly think that cooperation across industries, but also national borders, are a crucial method for us to generate innovative solutions. And I just wanted to give you this as a short example, because we really invest in international collaboration. And today we have partners in the US, in Canada, in Norway, in the Baltic countries, and hopefully soon also in Germany. In Israel, we have very strong partners. We just formed the task force on chronic disease, clinical research, a launchpad for startups, entrepreneurs, both Danish and Israeli, and a masterclass in healthcare innovation for public leaders. Some of the areas we work together on within the frames of FIRS. So my concluding remarks today will be, please do reach out to us for collaboration, and please remember to eat more cake.
Jan Kende, thank you so much. It's all about making the salad bowl bigger, or the cake, whatever you feel like. Mr. Meyer, please take the stage.
Hey, guten Tag. Das war jetzt die
So that was the Danish part of my presentation. I would love to continue in German. Thank you very much, Jan, for your presentation. Well, difficult to find the transition from cake to the German healthcare system, but I'm going to give it my best. So in the next 20 minutes, I don't want to discourage you. I don't want you to just emulate Denmark, but instead, I would like you to consider it to be encouraging and also as a motivation to do a little less talk and a little more walk. And if I manage to do that, then I've achieved my goal for today. So today I'm speaking to you as the Secretary General for the German Society for Integrated Care. And I could just actually give you the very same talk that Jan just did, but unfortunately we were not able to implement it all in Germany so far, just like Denmark did. So that's why I would like to start with the current status. Have we actually reached the tipping point, that point of no return? Is the legislation where it's actually supposed to be, what they promised us at the very beginning of this legislative term? Well, I would like to start just like Jan did. And Germany We always claim that we have the world's best health system. There is no better system. Nobody here can really complain about the health system. When we have an accident abroad or when we suffer from a certain disease, we always find help. So we're quite privileged here. I myself, for instance, got to work abroad and I got to go to a clinic in the south of Europe or in the US. I went to a clinic against fighting colds and they present you with a bill of $2,000, then you know you're doing quite well here in Germany. But we have to keep up that high level. And I believe we all run a certain risk here. If we keep talking and if we don't really walk the talk, then we end up with very bad figures. And I think this is well represented here on this slide. It's done by Ipsos. They publish it every year, and these figures become more and more threatening every year, but I'm going to spare you now. Here you can see that red tape is quite an issue. You can do your own litmus test. For instance, when you're an outpatient patient and you have to take a look at all the documents you have to fill in, and you can see that the administrative staff is taking care of that, and access to treatment is a problem worldwide, and the costs for the access to treatment, this is where we're doing quite well. We're above average, above world average. Since we have an insurance system that is based on solidarity, so we aren't leaving no one behind. We're not leaving the most vulnerable behind. Well, I think we can be quite pleased that we can also care for those who are arriving in Germany here now, and not like Merz did. I don't think that should be part of an electoral campaign. So these figures make certain things clear to us, and I would like to present these figures to you. Thomas Stillfried of the Central Institute carried out a study, and you might see how threatening the development of these figures are in the inpatient area. You can see in blue, and outpatient area is represented in green. And we can see that the age pyramid is not just not going well, but it's also quite threatening. And this is what you see in this blue box. In the next 10 years to come, we will have to replace 14,000 doctors that are going to retire or going to leave the system for other reasons. You might say now, well, there are certain programs that were launched by the Ministry of Research that might be able to mitigate that problem. But the other side of the coin is that, well, I mean, those people studying medicine right now, I'm one of them actually. I studied medicine, but I luckily maybe never actually took care of a patient. So 40% of the med students are actually entering the care sector afterwards. That's not enough. So we have to really well, I don't think that recruiting medical staff from other countries is the right solution. They're doing a good job, but then we're taking them away from Belarus or from Austria or from other countries, and then they have a lack. So we have to think about that problem. So it's very difficult to solve this issue. Well, we have identified the problem. Let's do something now. Well, for instance, in oncology, we have spelled out a great solution here to detect oncologic diseases early on, to treat them well, and to also offer good post-care afterwards. It's very similar to what you showed, Jan, actually. Here you can see an image of different stages, and when you're an expert, you might see right away that these areas are part of different legal texts and different codes. So very difficult to have a standard invoicing system or well, I'm just sending the patient from inpatient to outpatient care units. That's very difficult, and it's not a good system. We need to work on these issues, and that's what we are currently doing. Well, interestingly, we're not doing that nationwide. We're not doing that on a federated state level, but rather on a municipal level. We have certain projects that were launched and they're phasing out now because they're lacking the funding. In this area of oncology, we have more than 1,000 providers, but unfortunately, the cohorts of patients are usually very small and just a very brief period of time. There is no nationwide implementation. I'm not going to read out the text to you now. You can see those buzzwords, and you should keep them in mind. In order to really depict that patient journey, I mean, you can see that in every doctor's bulletin that keeps talking about that journey. We need a change of the remuneration system, of the admission system. We need access to ideas on how to further optimize the quality. I think we're doing quite okay, but we could improve here. Well, you also have to change professional law. So if we keep thinking inside the box, if you have certain medical staff here, some other professions there, that won't lead us to an integrated care that we hope to get and that we need. Number 2, the so-called health kiosk. That was a good idea by our minister. But this is not what he was talking about. And I used this image in a different presentation already. But this became more relevant now. So this is what a health kiosk is not supposed to be. This is actually from the US. This is what you see in China. And then there are certain German kiosks as well. I don't know if you've ever been to the US or Walmart. You can have your vital signs being measured there, and then you can get doctor's consultation, and in China you even get the right med afterwards, or medication afterwards, that is being given out by this machine. Mr. Lauterbach, our Minister of Health, was showing an image like that when he went to the pharmaceutical convention yesterday. And then he said, okay, this might be a cost-saving product for pharmacies. But his idea about health kiosks to really take care of those who are disadvantaged, who are vulnerable, who have difficulties, who are marginalized. So he wants to really take care of them. That's a very good idea. However, well, good intention. However, so sometimes it was even done, and we have to talk about that during the lunch break. So everyone's in favor of that, of course, but however, if we take a look at the drafts of if we take a look at the legislative drafts of health kiosks, we can see they are well-intentioned, but they are based on individual measures that need to be carried out. So we need to make sure that this is not only implemented in 10 places in Germany, but it's supposed to be expanded to 8,000 places in Germany, so it does need some revision here. So here we can see all of our difficulties. We need to work across sectors. We have to work across different budgets. We have to determine who's actually disadvantaged. I am from Starnberg, and those who are disadvantaged in Starnberg are those with an average income of less than 60,000 euros. So we have to determine that status. So as I said, it's well-intentioned, well done with regard to certain points, but these are individual implementations that are only well. But if we want to spread it out nationwide, we need to do better. And thank you very much to my previous speaker. We have to talk to each other. I can't just say, as the Minister of Health, that I'm going to order the statutory health fund to pay 74% of this health kiosk. And I would have to communicate, and I would have to talk about that figure. Why is it 74.5%? And I have to also explain why municipalities have to provide the space for that and why we can't do it on the national level. And we have to digitize things more. First of all, let me thank you for your invitation. I actually learned a lot here. I learned a lot about the speed in Denmark. I learned a lot that, as you said, you really want to walk the talk, not just talk. And I myself, I'm a board member in Austria of a bigger organization, and in Austria, the electronic file it was implemented because we had some advocates there, just like in Liechtenstein and other countries. So as I said, we should stop just talking about things. We should expedite things. We have to bring experts together and the important stakeholders here. You can see a paper that we handed over to the minister, and we're very happy that it was presented in the Digitization Act, and it was also part of the strategy of the Ministry for Health. And maybe you might criticize that if we had done that earlier, we might have been able to expedite certain things. But, we're learning our lessons. So our job now is to have a different kind of understanding of the protection of patients' data. I mean, patients' data need to be used in a beneficial way for citizens. It has to be reasonable. It has to contribute to progress in medical diagnostic and in medical therapies. Let's talk about the hospital reform now. I'm sure I could give 3 more talks on this issue, but who knows where we're actually at. I myself believe that it's good that we started this discussion. It's probably 10 years too late, but we opened up many minds. We identified the weak points in our system, and of course, we after all of the complaining and criticism, we need to really think about what we can improve and what we can do. So we believe that we're currently not on the right path. Once again, it is well-intentioned, but it's not right to just create another plethora of new laws at this time, which is happening currently at the Ministry of Health. This list is non-exhaustive. There are even laws missing. So I can't just present a list of new laws and be disruptive and trying to work across different disciplines and try to revise the outpatient-inpatient system. That's not possible. You can't just present this list of laws. Instead, they should find a common denominator. Well, it's very difficult to do all of that at the same time because you have new stakeholders, you keep setting up new goals, and you are dealing with different understandings of priorities. And to be blunt now, I'm very sorry for my colleagues in the Ministry of Health because they are creating these new drafts of laws and they have to work very quickly, and they have to present all of these drafts with extreme speed. So, I mean, but we can be sure that 1 year before the next election, they won't be able to adopt that many laws. So maybe our minister might have to accept the fact or come to terms with the fact that he won't be able to adopt all of these laws. He might be able to adopt some of them. Some might not even fit very well together. So that's already the end of my presentation. Have we already reached the tipping point? I believe we have. Well, finally, we are in a situation that's, of course, needs-based, that we cannot continue business as usual because this is taking away opportunities for Germany. We're not doing so bad, but we could continue driving down costs. Everyone here knows that in Germany we spend 1 billion euros in the German health system every single day. And I believe we all agree that either having the same budget we might achieve more, or achieve this what we achieve now with less budget. So I believe that we have reached a tipping point here, but I would also like to conclude just like Jan did. We have to wonder whether we have the right kind of conditions to reform our hospitals, to help our outpatient doctors, to offer better care across different sectors. We have to digitize all sectors. We have to reform our professions law. We have to help pharmacies. We have to make sure that we take care of the care sector, and we need to take all of these actors into account. And honestly, all of us together, and I'm not excluding anyone here, nobody should lean back. Everyone here is part of the system, regardless whether you're a patient, doctor, whether you're a representative of the ministry or of an organization. I'm sure that's a non-exhaustive list, but are we willing to take these actions and to revise the system? Or are we just going to lean back and say, well, it's okay, we can leave it like that? Or are we willing to really take a hands-on approach? We have to pay special attention to the patient. We have to think about what citizens expect from us. I might be the oldest person in the room, but I myself, I'm not very well socialized with regard to our digital world. You, as the younger generation, you will be handling digital devices. You will be able to do so, and you are probably looking forward to do so. So we should all contribute, and let's embrace Jan's invitation. Let's work across boundaries. Let's listen to each other. Let's learn from Denmark what worked well, what might not have worked well, and let's also talk about what we did well. I mean, we have done a good job as well. We need to work across boundaries. If I get to come back to my organization, rehabilitation organization, which is taking care of children that need transplants. So up to 10 years, they received a new liver, heart, lung. So those children are actually being receive rehabilitation in Austria in a special institution, and this institution is not publicly funded. Neither in Germany nor in Austria. It is dependent on public donations, and now they try to mobilize donations worldwide. So I'm talking about non-state subsidies, and they try to make sure that they can offer appropriate rehabilitation for these children, which is an amazing example. And if you have examples like that, I would like to encourage each and any one of you here to think of your personal contribution that you can make. What's my job in my environment? What can I do to learn from other countries, other health systems, other disciplines? If I'm an oncologist, maybe I take a look at other disciplines. When I'm part of the statutory health system, maybe I take a look at the private health system. If I have to do with the Ministry of Health, maybe I should take a look at other ministries that are dealing with these issues. So think outside the box, and also we should implement these ideas together as a team for the benefit of the patients and citizens in Germany. If we achieve that, and if that's what we take home today, then I think then we had a successful day. Thank you.
Vielen Dank an Michael Meyer.
Thank you very much, Mr. Meyer, Managing Director of the German Society for Integrated Care in the Health Sector. We are now quickly going to change the scenery a little bit. We're lagging 5 minutes behind, so we'll be able to do this. We have 3 workshops. Workshop on sustainability. That's workshop 1. And Ingela is the responsible person for that workshop. And I suggest we're going to do this quick and dirty. Left, right, and center. So if you go up on the left, Olaf, you can go out on the left. So workshop number 1, please follow Ingela and go to workshop sustainability, which will be in the Danish embassy.
Over i den danske ambassade. Nummer 2, workshop nummer 2, über patient.
And workshop number 2, the patient journey.
Should stay here, please, in the auditorium. And nummer 3,
And number 3, innovation in care. They should follow Olaf, so please follow Olaf to the Danish embassy, but you will go to a different room.
Yeah. So, first of all, I would kindly ask you, we have so much space, please move further down the road. Would be highly appreciated, because maybe then we have the chance to really more go into interaction. And as you see, we have more seats left, so anyone who's who really want to take part can jump in. We have like kind of a hot seat. You can join in the panel discussion, and therefore my really first question on you as an audience is a pretty easy question, is just to know who's here. Who's actually more or less native German speaking? Please raise your hands. And Danish? Cool. Perfect. I'm Jeremy. I'm the host of this panel discussion. And I'm here with several experts. Nikolai and Brian will start with a short presentation, and then we really dive into, together with Peter from MDoc and Lars now at Greifswald, formerly at the University Clinic at Saarland, and still project lead for the virtual hospital in Saarland. I'm Jeremy. I'm the CDO of the Johanniter, and the Johanniter is one of the biggest non-profit healthcare providers in Germany. So I'm happy to host this session, and I would kindly ask, and now comes the question, I don't know which presentation starts, so we will see who goes first, Nikolai or Brian. No, we will skip my thing, because we only have 60 minutes, and then it's much easier if we... Oh, yes. No, that was... So, we start with Nikolai.
Yes, thank you, and thank you for the invitation. I have a few minutes. I think I was given 5, maybe I'll take 7, let's see. Yes, my name is Nikolai Laugesen. I represent Falk. I will do this in English. If you have any questions in German, I think I will be able to answer some of them. I have a murky background at Humboldt University, so yeah, but it's 20 years ago. All right, so I'm not sure all of you know Falk as a company, so just a few questions. Falk is I wouldn't call it a startup, but we are founded in 1906. So compared to the church, we are quite new. Compared to other organizations, we are quite old. We are about 27,000 employees around the world. That includes South America. We have healthcare solutions in South America. We operate ambulances in the US. We have a number of healthcare and ambulance operations throughout Europe. In Germany, it includes, among other cities, Düsseldorf, Hamburg, Spree-Neisse, Leipzig, and a couple of other strongholds around Germany. Yeah, so that was a little bit about Falk. For today's topic, we have, over the years, been working on what we would call it seems like the slide has been changed a little bit, but nevertheless, I'll continue. How we approach the advance of sustainable healthcare, and how we define sustainable in this context is not only through the lenses of climate, but also through the organizational perspective. Sustainable in terms of our employees, the organization. Do we have enough resources? Can we deliver what we need to deliver to the patients, etc.? So what we have been working on for the past years is, of course, first of all, how can we bring down the CO2 emissions from our fleet, including about 3,000 vehicles around the world. We have electrified some of our ambulances. We have introduced hydrogen cars, and that, of course, is only the first step. We have also increased the number of virtual consultations. That is especially in our South American operations. I think it's about 40% of all our consultations are now virtual. We have introduced drones in healthcare. Why do we always need to move the patient if we can move the diagnostic sample? We have done that in parts of Denmark. We have introduced it in Greenland, a country about the size of Western Europe with 50,000 people, no roads whatsoever. So that's just a good example of how can we leverage the innovation that we are working on. And then finally, I think this is what is the most important for today's topic. That is the transformational part on how we can use the digital technology to keep patients at home. We normally say that Falk as a company, we are focusing all the stuff that are outside the hospital. So when suddenly you have the digital opportunity, you can actually be hospitalized in your own home. And of course, that is what we are trying to aim at. And I think we have the representatives of FIRS with us today. And the example that we were that Jan presented is actually on the right-hand side here, is about having the patients in their own home, supported by the right monitoring, supported by access to a digital healthcare hub, and also supported by our ability to physically go out and visit the patient when needed. You also saw the numbers from Jan earlier that we don't have these resources in this particular region. So we are now trying to use the resources that we have available. That could be lower skilled chauffeurs driving patients. We equipment with the right competencies for specific tasks in the house of the patient. That could be blood pressure, respiration and oxygen levels. But basically, the important part is that we are working across the doctors at the hospital, the telemedic link to the patient, and of course the continuous monitoring of vital parameters. You can say that is the heavy part where you are hospitalized at home. On the lighter part of it, what we would call the use of wearable technology to monitor, again, patients at home. We do this in Poland right now for about 10,000 citizens. In this way, we gather an enormous amount of data very fast. We know what kind of data to look for. We know when to react. We know when to react a little bit earlier than we were doing the day before. So the more data we gather, the more we can actually provide this necessary healthcare also before you can, in this way we can predict the patterns for each individual patient. I think that was my 5 minutes. So.
Lunch? Okay, so I will present you an idea, and actually it's Anders and Anders here is in the front. We are two colleagues at Bispebjerg Hospital together with the capital region, trying to, when we hear companies like Falck, and I know a lot of companies are here, how all the technologies they can present for us, how do we convert them to usable solutions within the hospitals? That's sometimes actually very difficult, and we actually already have a lot of technologies out there that we don't use. It's very difficult for us to implement them, even though it's very good advanced technology. How do we convert this into usable solutions? And for that, we sort of designed what we call the Behovsfabrikken in Danish, the need factory and our factory of necessities. And that factory has that name for two reasons. Within hospitals, we need to be better at structurizing what we need. What it is that we need actually to overcome the burden that we heard about today. And the idea when we have structured those needs, Anders and I go and talk a lot to nurses. What is your problems today? How can we help you, so to speak? And then we structurize that a lot. And then that need, a need could be reduce the amount of infections in the hospitals. Okay, that could be a need that seems to be a troublesome in the hospitals. And then we take that need and tender that need directly to the market. Okay, instead of considering what is the solutions, what are the technology, we tender that need to the market. And to do that, we use, and also back to what Dr. Meyer said, instead of revolutionizing the healthcare, maybe we need to take it bit by bit. Okay, so the vision that Anders and I use all the time is to use what we already got and use it a little bit better. Okay. So we're actually using a very common EU tender that is called a partnership tender, and use that as the media to transport that need into the market. Okay, open the hospitals, let the clinicians be clinicians, and let the market come in. But we cannot just, since we are public hospitals, we cannot just pick a company and do partners with them. The idea is to tender that market or tender that need with a partner, and actually upfront make the contract of the buy upfront. In Denmark we are world champions in doing public-private partnerships. but we are the worst in sort of affecting the value of that partnership with it into a clinical solution. We do not buy it afterwards. Okay? So why not do that up front? Make the contract. If we co-create something together in the partnership, what we co-created together, actually you as a company own that. We got the fulfill of our need, and then we buy it. Okay? But then we allow you to be at the hospitals. So in the beginning, what we do a lot at the hospital, we structurize needs. We value those needs because that's also very important. If nobody is willing to pay for the fulfillment of that need, then forget about it. Then it's just the technology you want to buy. Okay? So you need to work within the hospitals. What is the willingness, if this need or problem is gone, what is the value of that? Okay? Then we take that money and set it aside, and then we do the tender business. And then actually, the problem you have in the private partnership is that you don't buy it afterwards. So we value that. Then we go to the market before we do the tender. That's the fourth one, we do the tender. And then we ask the market, how should we structurize the tender? Okay, what can you do? If, for instance, infections reduction, what are the possibilities? Where are the easy, low-hanging fruit that we can do? Okay, so we don't make a sort of stupid tender that's just, too difficult to realize. Remember that we're trying to do small steps here. And then based on the need, the value, and the market dialogue, we actually do a tender. And that tender, you will win a partnership where you do innovation or market development or improvement or adaptations or combined technologies together with us at 2 hospitals. In this case, we have the first one is coming out. That will be at 2 hospitals and actually partly at FIS, actually. So we're trying to do, so we try to, whether that could be in 2 regions, actually, where we co-create that solutions. And the concrete example is that we have a lot of new hospitals in Denmark that have single rooms, and we're going from multiple patients in a room to a single rooms. The overview and the coherence you have when you, as a nurse, work with multiple patients in a room. You would like, if you're a patient, you would like to have a single room, but if you're a nurse, you would actually, the care is actually easier to do in multiple rooms. So that coherence or overview you are lacking when you're going from multiple patients per room to a single room. The tender is create that. Okay? So there's actually a little bit of a crazy tender. We don't talk about what the solution is. So the stomach feel of the nurse, when she has an overview taking care of 4 patients in the same room, whenever that 4 patient is positioned in 4 different rooms behind a locked door, or closed door, maybe not locked, that would be too much. So that's create that feeling. So we co-create that for a year and a half, and then if we succeed with that, then we have, you remember the money we set aside and the willingness to pay for it, then we buy it. Okay? So we call it sometimes a reverse tender, sort of expose the needs, and you can do that. So that is the way we do innovation in my hospitals, to structure the way that we want to do partnership at the hospitals. So partnerships is a general theme, and we have different ways of creating those partnerships, but we base it on specific needs that needs to be solved. Okay? And that's it.
Perfect. I would say just have a seat. I bring water. As you wish. If you have questions, do I need the micro? I would say thank you, Nikolai. Thank you, Brian, for your introductory presentations. And I would say my first question goes to Lars. As we talked about implementation of innovation, and first of all, Nikolai mentioned, for instance, healthcare monitoring, which in Germany is still in the at the beginning because of reimbursement numbers, I would say. So the German healthcare system it's literally fragmented. I mean, we have the different sectors. We have around about 1,900 hospitals, not often talking to each other in a way. As I see, it's very difficult to widely adopt innovation and to bring it all over different sectors and hospitals. But you managed this with the virtual hospital in Saarland. You're still the project lead. How did you do this?
Okay. Yeah, kind of. I think it's a problem. We talk about innovation, we talk about partnerships, and we talk about projects that have to combine outcome for the patients and outcome for the hospitals. But what we do is we set only a little project here and a little project at the other hospital, but we get no outcome for the healthcare system. And what we did in Saarland is we tried to combine some projects, some visions, some ideas. And with the start of the Krankenhauszukunftsgesetz in 2020, we had the idea to combine patient portals with all the hospitals in the Saarland. And we built an interoperability platform. So we have the first step. We only not only talk with our patients. We can talk. We can exchange our documents, our information with each other. This is the first step to our virtual hospital in Saarland. We have, I think, 4, 5 different phases for this. We take the money from the Krankenhauszukunftsgesetz. We have a good start to implement an interoperability platform. So the patients have only for the Saarland one app, one website, one system to talk with. And the next step is we get our doctors in the field connected. We get our doctors on call connected. We okay, yeah.
And how did you?
It's okay. It's
yeah.
okay. I hear you.
How did you manage it like within the hospital? Thank you. Sorry. My name is Marcus Serene. I work for Rumble in hospital logistics.
Okay, first it's a long way to talk to all hospitals. I went to every hospital. I come from the technical side. I'm CIO at the University in Greifswald, and I came from the technical part. So I talked to the CIOs, and we had all the same idea. We had the same vision to do something together, because technically it's all there. We can build everything technically today. We need not the big innovations. We have to do the first step, because it's all there. We have only to do it, and one have to do the first step. So it's a lot of talking. I think 1.5 years only talk to each other to get the right way, to get the same direction in mind. And then we had an Arbeitsgemeinschaft with the Saarland Krankenhausgesellschaft. So we had something that heads up the whole project.
Very, I would emphasize that and very good, because it shows that innovation is a long haul. You need to do that kind of work, and there's also a disease in Denmark where people think we need that one radical innovation that sort of solve, treatment at home and patient and stuff like that. But the infrastructure and the innovation, and it needs to be there, because there will not be that one. We do not need a better Holter device or better app or better before we have the structure in place. So that's a good point. I think that's a very good take-home message for this. That one innovation doesn't exist. It's the infrastructure you need to and that's the long haul.
Okay, and we set up the infrastructure for this innovation. One of the next steps is to have our data repository fully functional, so any innovation can set on top, and we can quickly use more innovations in the field that we can have now.
Oh yeah, sure. My name is Ole Grønskov. I'm from a software company called PDC, and we have a solution for helping you with the shortage of nurses. But that's not the reason why I was up here. The reason why I moved to the better seat here was because Nikolai, when he made his presentation about Falk, and I saw the ambulance, I just remembered a few months ago, my mother had a stroke, and the neighbor called for an ambulance, and then she called me, and I raced to my mother. And when I arrived, I saw my mother in the ambulance, and they started, in Denmark we have this, we have all the patient records. They're connected, so they have all the data for my mother inside the ambulance. But they started treatment or looking into her and make initial measurements. And based on that, because they were connected to the region, they decided to go to another hospital than originally, and thus meeting the true experts in exactly her field, because it was not what they had anticipated upon arrival. So because they had measurement and started making treatments in the ambulance, they decided to go to another hospital, and that's saved my mother's life. So I'm truly grateful that that I now understand that ambulance service is not just about bringing the patient to the hospital. Sometimes it's bringing the hospital to the patient and starting there. So I'm truly grateful that you have that service, and it's a kind of bottom up about the problem, because we have the technology, so it's possible to do so. But for you, it's natural. It's like that. But this is, in my perspective, a true innovation and a true new way to deal with these matters that we where we see a progress, a true progress. And I'm grateful for you were there. Thank you.
Okay, if I may comment on that, well, I'm glad we were there. One comment to the use of ambulances. Sometimes we refer to the ambulance as the first part of the hospital you meet, and we have advanced the technology inside the ambulances, the sharing of data, etc. But I think there are also another innovation or development that is equally important. And we have done that in a public-private collaboration with the Sygehus Lillebælt, the hospital of the Little Belt, directly translated. This particular project is actually aiming at keeping the patients out of the hospital. So normally, when you dispatch the ambulance, you scoop and go, as we call it. But we see more and more the opportunity to dispatch a smaller vehicle with direct link to the hospital. And then the paramedic on site can make a quick decision together with the doctor to keep the patient in his or her own home, or where it might be. Because we do see a lot of patient transports. We do see a lot of admissions to hospital that are not really that necessary. And it can be, as for example, in the hospital of Nykøbing Falster, it can be quite a big burden to have all these patients coming in without it really being necessary. And we see the technology, we see the opportunity in the technology and the direct link to the hospital, that in that way we can reduce the number of admissions to hospital. I think it's about 30 to 40% in this project. And that is, also from a cost perspective, that's a cost driver to keep the patients out of the hospital.
That's an interesting point. As we see in Denmark, this patient flow system and the patient flow management is something we can't miss in Germany. But when I look at Peter, at least a patient portal is kind of a step of a patient flow. Can you bring on how the patient portal and the innovation of a patient portal really is something which brings in convenience for the hospitals and the hospital staff to, as we see, we lack resources. How can AMDoc help to solve this problem?
Thanks. Yeah, my name is Peter. I'm worked around about 2.5 years for AMDoc, and our focus is at the moment patient portal in Germany, Austria, and Swiss. And before AMDoc, I worked 30 years roundabout for statutory health insurances. There was no need to speak English. Sorry for my English, it's not so fluent. But for the statutory health insurances, with the services in Germany, they're always one step behind in the chain Behandlungspfad. In the pathway, yes. And I met Admir after the funding AMDoc 2016, and he called about platforms in healthcare. And he come from the telemedicine sector, and this was fascinating for me, the opportunities with a patient portal to get the right information, the right service at the right time in the Behandlungspfad, in the pathway, patient pathway. And in Germany, we always speak about a patient. The patient is in the middle, but that's not really so. And I think we have also faced the families with the patient. They always or often decide really important things, and children for their parents, parents for children's partners. And with the patient portal, we got the opportunity to get them with the patient and with the information by the side. And in a moment in Germany, Krankenhauszukunftsgesetz, Hospital Future Act in 2020 started the process to digitize the hospitals, the acute clinics, and this is a great chance for us and for the clinics to show what can we move in this digitization.
My next question goes to Brian, and it's regarded to something Jan said about skepticism in Germany. From my point of view, innovation only flourish in places where the culture is ready for change. And as in the past, the title was kind of procurement, and from my point of view, it's easy to procure innovation, but it won't live in a way or will highly adopt it. So is the Danish culture more open for change and innovation? And or did you need really to prepare your hospital employees for this openness and this adoption for innovation? And what can Germany learn from it?
Yes, actually, when Anders and I worked, the Achilles heels in our sort of project is actually our own hospital. You know, the nurses in the hospitals is not that ready for change, you know, because they're busy. But what we're trying to do is to make that platform where they need to change. So if you just do a daily clinic, and do not see the necessity and the possibilities to do a change. So the idea in the way we do innovative procurement, because procurement itself is very boring, but even innovative procurement is. But the idea is that we take the companies inside the hospitals, you know, so they co-create that kind of stuff. So they will be there, you know, the partners will have offices at the hospitals, so they will co-create. So instead of, you know, when digitization is just something that sort of, if Nikolai just brings a product, you know, it's a different task if he comes and says, let's co-create a product, you know, together. And I guess you also do that with MDoc. I bet you try to incorporate, you know, the families. How should we build it together, so to speak? But that platform is often difficult to be. It doesn't just come from the heaven. You have to sort of create that platform. But it is, you, of course. So the learning we could give you is to sort of say that you have to do it, you know, just don't take it for granted, that readiness. Because our nurses, often when Anders and I book a meeting, you know, they could say to us, we don't have the time, you know, so we are often actually not that prioritized. But they have more and more interest in the way we work, because they can see that it's interesting. If there is a new technology there that would like to be involved in that technology. For instance, we have the tender we have now is about surveillance of patients in a patient room, you know. If the manager of the hospital bought that system, that's a very different story than if the nurses co-created that system with a company. So the storytelling of that is very, very different. So you need to create that spaces. Okay, so if you didn't create that, then the openness will be absolutely zero. Now it's maybe 1%, because, you know, you will sort of open the door a little bit, okay? But I think the trouble that we have with nurses being willing to adapt technology is more or less, I guess, the same in Denmark as everywhere, because they're so busy, okay?
Nikolai, you collaborate with a lot of hospitals. So what is your recipe for success? And in a way, if you really just co-create, then you have a single solution. You can't scale in a way. So how do you make it a scalable but highly adoptable product? What's your recipe?
Well, if I had the recipe, I wouldn't sit here. No, I think starting somewhere else, I think the healthcare system, whether it is in Germany or in Denmark, I mean, healthcare systems are highly complex. You have to include the hospitals, you have to include general practitioners, you have to include municipalities and the primary sector. You have various financial flows coming in and out of Krankenkassen or hospitals or whatever it might be. To understand these complex system is one thing. And then when you have understood that, then you would need to co-create, because otherwise, if I just come with what I think would be the best possible solution on the planet of Earth, there will still be pockets here and there say, that might be a good idea, but it doesn't work in our context. And I think when we have the public-private partnership with the Hospital of Nykøbing Falster and together with the FIAS organization, I think the recipe here is that we spend time on the patient journey, we spend time on understanding the needs of the hospital, as well as they try to comprehend what is it actually that we can deliver. And I think having the space to do that, I think it's more or less the same space as you were talking about, Brian, but having the space to do that is valuable both for us as a company, but also for this entire process of creating a new solution. So, I mean, the co-creation, okay, that was the easy part. The scalable part, yeah. We have seen, I think that's what you're referring to as well, a lot of pilot projects throughout Denmark, throughout Scandinavia, and none of them has really scaled. We have seen attempts to do a national telematic solution. I was part of the process back in 2017. It might go into operation in 24. So that has taken 7 years to try to create a national top-down solution. During those 7 years, the technology has developed super fast. So I think the idea of think that you can foresee a full-scale national solution that is scalable is just more or less impossible. Otherwise, you have to do it really, really fast because the technology is developing. The needs of the healthcare system from 2016 or 17 to today, I mean, we have seen the numbers, the increase in the number of chronically ill patients, the decrease in the available resources. So the long answer to your short question is that a scalable solution that will be thought of and implemented top down is very difficult. I think what Brian refers to in this kind of procurement process is actually a way of getting solutions and products faster to the market. Whether you can do that in a scalable way across hospitals is another thing. I think it would be a good idea if we can combine more hospitals in their procurement process, because otherwise it would still be a minor project at some point.
Often when you have the startup companies, startup company often do not understand the complexity of, they would even see, the reason that you do not buy my product, I guess, is because it's not invented at your hospitals, that kind of stuff. Because the complexities that we say no to stuff and that we do not implement a cool product or too cool technology at a hospital is much more complex than that. You can imagine that it could be long term, we could have bought a stuff in Epic, we could have, the complexity of why technology is not at a hospital. Often we see startups not understanding that kind of arena, and maybe the infrastructure you're supplying isn't there. So you have there's nothing to build it on. So you have to be very open. Also, if you want the technology to help them a little bit to navigate how to get it in, because the technology itself is not enough.
And what you said about fastness, we've been working on the electronic health record for more than 20 years. So,
Boje Eliassen from Copenhagen Institute for Future Studies, and I'm also a fellow at the Robert Bosch Stiftung Academy. So thank you very much. I think this is very interesting, and you all alluded to it, and we also heard it in the talks in the beginning, that we need to think differently. And I'm fascinated by the way, and I of course I've worked a bit with Brian, we know each other, and I'm really fascinated by his way of doing innovation. But what we are focusing on in this part of the patient journey is when you are having what I would call severe problems. What we're dealing with today is that the disease burden has grown very, very fast the last years, and there is no way we can deal with that in the common way of thinking. So my question is, with all your expertise, how do we get earlier in? So precision is one thing, but timing is probably more important. So how can we work with the civil society, with the municipalities, with the regions, with the approaches that you have, so we actually can reduce probably the second chronic disease, which gets complexities in, and use data in that part. And I'm specifically asking because Germany is looking very much at Denmark. Denmark is very good at some things and has challenges in the same way as Germany in other things, but everybody has this challenge that the disease burden is growing much more than it should.
I will first ask Lars to answer this from his Saarland point, but also from the Mecklenburg-Vorpommern point.
One part in our project in Saarland is this thing. We have to connect to patients so we can see further if comes an illness or something, because we today we have not enough data, not enough possibilities to look at this thing. So we want to collect in the whole data platform trackers, some services for patients that they can put in some data on its own. And we collect the data. We want to we talk with one firm to have an AI to look over all these things. We have many of pathways today. So if some kind of data set is reaching out to the normal space, the patient gets an info. Okay, might be something is wrong. Please talk to your doctor. Let's check it. And this is what can possibly get the patients connected, so they get the opportunity to check their healthness very good, more further, and so they can get very earlier to the doctor and not to the hospital. This is one part of our thing, and it's not only AI. It's AI is just a big thing, but we have the opportunities with pathways also to check the medical values every day they come in.
From Oracle.
what is it? Is it help them to become the best?
The patient is only one component. The insurances are components. So we try to think in a, what data do the ecosystem need to scale? That's where we're thinking. Maybe it's not the best for the patient, maybe it's not the best solution for the hospital. Okay, it's fine, but we're looking on big picture, or try to.
And this is an interesting point. Like, especially if we think about population health management, and maybe something where the regulatory part or governments at least now try to do a bit, but still kind of afraid. But we have now things about the Hospital Future Care Act, where we have like convenience part, which is the patient portal, but now pressuring also the hospitals. We have the hospital reform, which more and more puts the pressure on hospitals. We have a staff shortage. So thinking about MDoc and patient portals, how can you, in a way, help all these hospitals to come up and to bring the patient portals into life and bring this innovation into the daily life of nurses, of staff? If you really miss the IT department, the IT staff, and even the caretakers, I would say, for the projects in the hospitals, who really think of they are responsible for the patient portal to be run. And if I'm thinking and seeing hospitals, it's kind of still a very difficult part to at least put in the thing of that you open up your calendars, that patient can do their own and schedule their own treatments.
Yeah, I think we will see with the patient portals what hospitals can do. Hospitals are in the moment under great pressure. The other professionals in healthcare in Germany, in my opinion, they are not under pressure enough. The physicians, they had enough patients, they get paid, they don't need an innovation with telemedicine, telemonitoring and others. Hospitals must do that. And I think also in ecosystems, we need ecosystems, and hospitals can one of the initiators from ecosystems. And when the patient will be in the middle, the EPA, electronic health record in Germany, will not help him. We need one digital identity that works in the EU and not with his health insurance. I'm one person, I got one driver license, I'm with one insurance company, and I want an easy digital way to get services. And the patient needs transparency. Transparency about the services hospitals will provide or physicians will provide. And the patient must then decide, I go to a physician and go into the practice, or I search physician only per video call. And this is, I think, another way of thinking to get the informations about opportunities to the patient. This is not really good in the moment.
Yeah, it's really interesting to see what the technology can bring us and what solutions we can make for the future. But I was a little provoked by the fact that we are talking about the shortage of nurses all the time, and we're thinking that technology should solve that problem. But the fact is that we also put up administrative barriers to increase that shortage problem, because it's not only in Germany, it's all over Europe that we have a shortage of nurses. At least in many Danish hospitals. We know that nurses, they have a very busy schedule, very busy workday. And we also heard from Brian that they have tons of apps to deal with. And in privacy, they also can handle many things like, buy travel or order hotel or whatever you do on your mobile phone. But when it comes to the fact that a nurse wants to swap a duty with another, what happens then? Is that something she can fix on her phone? No. She has to go and deal with the king of the ticket counter to ask and beg him to change and swap that shift with someone else that you have even already prepared. And how do nurses react when they had that barrier too many times? They say, instead of working full-time, I go 25 hours instead, because then I can just go out and do extra time in my spare time, and then the hospital buys that service from another agency, paying twice as much as they should, because they don't address the problem that she wants sometimes to swap a duty with a colleague. And it's cumbersome to do. And that's not about technology, because the technology is there. You can easily set up an app to fix that, so the nurse doesn't have to deal with the king of the ticket counter to fix that schedule. But we don't do it. How come we don't address that problem? Because I tell you, you have no shortage of nurses in Germany. You have the highest number of trained nurses per capita in Europe. Think about that, and think about finding ways to make it easier for the nurse to swap duties, because then she might work 5 hours more a week, and then there is no shortage.
One point I like your point of the ecosystem. But if we look to the hospitals, and that's also your point, the status of digitalization in the hospitals is very, very low. We have also very much paper. We have nothing databases we can deal with. So I think we have a little bit too much innovation in our minds, too much ecosystem, too much everything. Nobody comes to the stuff and hear the stuff what they need and do these things. We have enough. We don't have enough money. We don't have enough capacities to do this. That's the problem. We don't do these things. And that's my point. Everybody in the healthcare system has to do his first step. He has to move, because that's the whole problem.
First of all, I think it's a very good remarks regarding how we can help the nurses in the system, and also what kind of role technology can play. And I also like to refer back to what our moderator said in the first part, stating that the concern about technology from patients. I actually think it's a little bit different than that. I don't think the concern about the technology is from the patient. Of course, we do see variations in the digital literacy across patient groups, but I think the biggest concern about technology is sometimes from the decision makers. We have asked patients what they think about the use of technology in their own home, and they favor it as long as they give them the more safety and freedom in their life and the ability to cope with their own chronic disease. So in that respect, I think we should embrace the technology because the patients wants to embrace it. And I think to reach out, I don't think we have any of. I think we all agree that we do see the opportunities in the technology here. So I would also like to reach out a little bit broader to say those that are against this is probably somewhere else in the system. Maybe not the ecosystem. I'm not sure about that, but yeah.
Problem as well. I give you an example. As what my place of living here in Berlin, am I still looking for a private practice with a doctor that is willing to work with me on island? It's not possible. There's the old paternalism problem. I'm the doctor, I'm the healer. Sorry for the doctors in the room. You're the patient. You need to do what I want you to do. So there are two things for me. The first thing is a change of culture with the new doctors. I hope the new generation of doctors will fix it, hopefully. And we need to educate the patient that is their responsibility to do something for their own health. What I see here, when I see my grandparents or my parents, they have sometimes such a culture, they're sitting at the doctor and the doctor, okay, what's the problem? I'm feeling not good. Oh, okay. So what is your problem? And then it comes to waste of time. I said, okay, before you go to the doctor, make some notes and say, that's my problem, that's are my indicators, that are my values, and so on. So give it to the doctor that we can shortcut a little bit the process. So we need to help to bring the patient in the, I would say, in a more mature level on a discussion. And we need to motivate the doctors to accept the eye level between patient and doctors as partners. And that's a cultural problem, especially here in Germany. My wife is from Portugal. It's completely different there. It's my understanding. I was there, and my feeling was the doctor understood that he needs my help, me as a patient. Here in Germany, I don't see that so often.
So we are running out of time. I'm at least a bit starving, but kind of going with my last question, if it's okay, I would kindly address Jan. As we have mostly German speakers in the room. So, and what we are really currently facing is kind of the hospital reform, something you already have done in Denmark. And my first question, and please be brief, is how painful was it for Denmark and the Danish society, and did it improve patient care, outcomes, and convenience?
That was a big one. just a short.
Actually, I can do it very briefly because we're not there yet with the reform, and it's still ongoing. We have a structural commission coming out with recommendations beginning next year. In Region Zealand, from our part, there's we're in the processing of merging 3 hospitals at the moment under one roof. The board of directors in the region of Zealand, they call the process sustainable hospitals of the future, which means actually that we now try to find ways where we can commit some of the doctors actually to give care and treatment to those most in need in the rural areas, so that we can find ways so that we can actually give the services that they have right to. And I think the structural commission, I hope that they will also give recommendations in the same way to see how can we, what do you call it, ryste posen, it says in Danish, so that we can actually shake the bag and actually try to relocate some of the resources and just, okay, we're completely online. We need some incentives. We need also not having a primary and secondary sector in Denmark. We need clear incentives so that both region municipalities, they can see the idea of giving preventive healthcare. Thank you.
The reform that created the regions that we have, the capital region and the region Zealand, and the point with Jan is that this is, it's not just one step, it's ongoing all the time, but the trouble, the issue you had about, the doctors sort of being the kings, of the castle, actually removed a little bit. So the big decision about great digitization within the regions, so in Denmark there's a big argument, Systematic has, the western part of Denmark and EPIC has the other part, but still we have big digitizations. And that is due to the reform. So the big decision, because if you ask the doctors, would they like this big system, they would probably say no. So we had a big ecosystem saying this is the way we're doing. It's not a popular choice, but what we're doing is still. So this kind of decision, and then we try to fix. And my point is the last point is my have is you have to do it. You didn't say it. You have to just do it. And because otherwise you wouldn't go anywhere. So the people dare to do it, like you're doing. Lars, you try to make a fundament to build on. If that fundament is not there, and in Denmark, I would say that the sundhedsreform, the regions, even though they're not that popular in Denmark, is the reason that we are so digitalized in the healthcare sector.
So thank you very much for all the panelists. Thank you for your time. My statement would be that, from my point of view, I see a lot of similarity and challenges the Danish system and the German system faces. There might be niche differences, but in the end, it's the same challenge, especially what we saw, what Dr. Meyer and Jan stated, that in the end, it's very similar when it comes to outcomes, when it comes to location of care and allocation of care. We have the same problem in Germany. We have areas where people from the best area and kind of the worst areas, they die at 10 years earlier than the best areas, something no government want to address. So I would say thank you, Brian, thank you, Nikolai, thank you, Lars, thank you, Peter, and thank you for the courageous move of Ole, who stepped in for the hot seat, and thank you very much for the audience. And now let's go upstairs in the first floor and have something to bite and continue the discussion on a brief, on a closed level.
Welcome back to the Audimax. I would also like to welcome our panel. Everyone's in the hot seat. Is that what you say in German? I hope you learned a lot today. I hope you had a great exchange. I hope you learned a lot from each other.
Und jetzt haben wir vor,
So, what are we going to do now? Well, we try to make it as digestible as possible. We try to keep it to 5 minutes each. So everyone is going to present the outcome of their workshop. Melanie Philipp, she's going to talk about she's actually working at Pflegepioniere and she attended the first workshop. Then we have Frank Zukowski from the UKE. He actually attended the sustainability workshop. UKE, did I mispronounce it? Jeremy Dame from the Johanniter. And you attended Patient Journey. Okay, so Melanie was in the third workshop, sorry. So I suggest that you try to stick to a minute when you describe your workshop. This way we can somehow facilitate a dialogue. Mr. Meyer promised us to really help you to dig deep now and to really kick off the conversation. But let's start with Mr. Jeremy Dean. Very difficult to really put it into 1 minute only. I'm going to speak as fast as possible. Well, we addressed different topics. One important topic was that the Danish healthcare system is very different from the German healthcare system. At the same time, we're facing very similar challenges. Jan gave us a great presentation. Dr. Meyer gave us also a great presentation. Basically, we had a lot of similarities. We share the same challenges. We have regional dependencies. We share socioeconomic challenges. We share, that's what I talked to Jan about, we share the reform-related challenges. Denmark started before us, but it's still ongoing. So what we see now is that we're all facing enormous challenges. And if we pick one hospital in particular and we try to put into practice innovative approaches, but this creates a problem. We focus on one hospital only, but we don't really pay attention to the region as a whole and the population as the whole. And with regard to the future hospital law, everyone is streamlining their own hospital, but not their region. So this is really taking resources, taking funds and staff. So it seems that we can't apply individual cases to the region as the whole. So we're helping out certain hospitals and not the region as a whole. So I think we should follow up on that, but it's of course very difficult in Germany to get everyone on board to have that overarching vision guiding us towards 2035 with regard to health. So I'm also going to pick up on that in my minute. We talked about innovation in the cure sector. We tried to find a couple of good examples, best practices that already work and that are already innovative. We talked about virtual hospitals in Great Britain. It's already providing care for more than 100,000 patients, and there's telemedicine in Vechta. This is where I'm working. We try to link different actors on a municipal level, and we try to be a stroma provider for the future, so stoma care. How can we facilitate support virtually? And it's also about a so-called e-district that was presented to us. So in Denmark, we can see that there's already this interconnected approach, and we had that great fishbowl method that we applied, and thankfully it also worked. And we got to talk to representatives from the long-term care, from hospitals, municipalities, architects, and also SHI representatives. So, well, we tried to identify solutions and problems. I believe what was interesting for us was to identify differences in our systems, and there are two things that I found striking. Number one, it's that attitude towards digitization. They are more open-minded. Unfortunately, there's less open-mindedness on behalf of professionals. Whereas in Germany, we keep postponing digitization. So it seems that they're using faxes or prefer using faxes than other methods, and that won't create any progress. In this, something that I found striking was that in that e-district, we have 108 active participants. I think in total we have 113 participants, and that would not be possible in Germany. Innovation with 108 people, so that's something that's inconceivable in Germany. But it's great to have that approach to put an idea in the middle of society. My seat keeps getting hotter. Thank you. So we talked about sustainability. We had two great presentations by Nikki Bai from EUCOM and also Alina Mittag. It was about the development in hospitals. There's a great need for action. Everybody has understood by now that the health sector accounts for 5% globally for the CO2 emissions. So they are generating many emissions. Finally, they have created a more structural approach via the EU Green Deal. So this is actually not just applying to the health sector, but across all sectors. We have that mandatory reporting system now, which is important, structurally speaking, because we have very different structures in these hospitals, sometimes small regional ones, then you have bigger university clinics. And this new reporting system is very similar to the annual statement reporting, and you also include auditors here. So it does add significance to the reporting system. It does create a lot of pressure to act. And now we have this regulation-based documentation system that's going to be introduced. Of course, we need more other laws, new laws for funding and for structuring. And finally, we're getting started here. Thank you. So let me just ask you a question right here, right now. I would like to start with you, Mr. Arden. You talked about Mr. Den, you talked about population health. What can we learn from Denmark? There is a second mic, by the way. Okay, let's not, what you just did pretty much, that's what we learned. Not sticking to your own mic, but rather sharing it. Data belong to patients, but we are the administrator of the hospital, and we treat patients' data as if they were our own. But we can keep fighting about the digital file, and it took us 20 years to implement it. But once that file is finally there, we can act just like it's being done in Denmark. We can have a patient flow data system. So the patient is sent to the best fitting hospital, starting from your journey from at home, from the moment that you're being picked up by the emergency service. So I'm just talking about emergency services now, but if we apply this to chronically ill people, or those people actually, patients in the system currently in Germany are pretty much lost. Nobody knows who to approach. Every doctor pretty much is applying their own standards and procedures. It's not really beneficial for the patient, especially with regard to chronically ill patients. They want to be guided. They want to be part of this system. That's what a doctor also wants. But that doctor is being prevented from doing so because we have that, because nobody is capable of sharing patients' data. A doctor can only do his best based on what's available. Would you now suggest a remuneration based on the quality of the services offered? Oh, that's very difficult. Honestly, who provides quality? How can we prove that? We have capitation models in Spain. I'm quite familiar with that. Before that, I worked for Helios Fresenius. They took over a different company in Spain, and it was very interesting to see that patients are being allocated to certain hospitals. They're allowed to switch hospitals, and that money is then also allocated to a different hospital. And this way, they have a more patient-convenient way of dealing with things. They're heavily focused on the patient, but it's very difficult to work across these very different sectors. In Spain, there are no GPs pretty much. Everyone's working in a hospital. The hospital knows everything about me, and in the best case scenario, I stick to or stay in one hospital. But I would rather ask, do we need the Israeli model? What's your answer to that question? Well, my mother used to teach me not to answer questions with counter questions. That's quite rude. Well, it's an interesting model. We keep fighting about whether we have too many doctors, hospitals, SHIs, or funds. Are they capable of knowing everything about their patient? Well, at least what we notice now in a more digitized world, it's getting more interesting if you have a system that manages all of the patient's data. We always attribute that responsibility to the patient, but he can't do that. I mean, there has to be at least one so-called data owner, and allegedly that's supposed to be the patient, but he doesn't even receive his own data. So we need that administrator of data, someone who monitors these data, administers them, and is using these kind of data for the medical use of the patient. I think it was you and Jan who suggested that. Only then we can start thinking about prevention more. Now we're not acting in a predictive manner, but what we do at most is secondary preventive treatment. Someone who's sick shouldn't become even more sick. Yep.
Bei Patient fällt mir jetzt.
Now, when talking about patients, I immediately think of care, because it's so close to the people. If you had two wishes that could also be fulfilled and that are related to care and digitalization, what would you wish for? Well, I would say I want to have a data language for patient care, and I would wish, and this isn't limited to care, but to all healthcare professions, a true professional legislation. Okay, a data language for care. We do have the vision of getting there, but in Germany we have the problem that we don't really have a data language that was developed here, also developed in German, in the German language. We have a lot of possibilities with diagnoses or output measuring that we could embark on that path, but it's not being taken into consideration when it comes to caregiving, and it would be the prerequisite to have a type of performance right. So this means we would be going into a care performance based on quality, and it needs to be clearly defined with standards, etc. So we could really establish something like this and give caregivers the opportunity to really pursue their profession and have a benefit legislation. Now, we very much focus on Social Code 5, and caregiving is not included in the Social Code 5. It's included in another chapter of the Social Code. Do you experience that in your everyday life? Well, yes, I do. One or the other care aspect is included in the Social Code 5, but that's the problem of the social legislation in Germany in general. I don't think we have to open up that can of worms. We do have the situation that, and that was one of the relevant topics that we did talk about, we do have the situation that the question of who is responsible, who is the one who can make decisions, this diffuse responsibility leads to a situation that nobody is assuming responsibility, and decisions are pushed from one chapter in the social code to another chapter in the social code, and at some point it ends on the doorstep of the municipalities, and then they say, what, since when are we responsible for that? And this would have been the third answer to the question you didn't ask. So that is why I am in favor of establishing a new type of professional care that is enshrined in its own legislation, whether it's a care social code or whatever, but as it is included in social code 5, 9, 11, and 12, and elsewhere, it is very difficult for us to really get a hold of it. And the second aspect in Germany is private caregiving should be equal to professional caregiving. We have social code 11, which allegedly is a care focus, but it's not true because the remuneration structures of professional caregiving are not reflected there. Okay, thank you. Let's look at the third workshop. Innovation in care. I participated in that workshop, so I have a little bit of insider knowledge. Now, what I've noticed over the course of those 60 minutes was that reporting with regard to sustainability will in the future be of equal value than financial reporting. Doesn't that mean that we have two worlds colliding that cannot be compared? Well, when it comes to KPIs, I mean, sustainability reporting will be based on KPIs, including the necessity to define targets and target achievements and questioning these targets regularly. And as soon as targets require funding for measures and for the support of these measures, it will be congruent to the other financial reporting standards. We talked about hospital funding, capex, and investments, etc. So in those areas, there will be a confrontation. In addition to the fact, and I mean, those are always the annoying questions. Sustainability inside of hospitals needs to be made public. There needs to be awareness raising. But in the financial sector, this collision exists because sustainability needs to be paid, and if you really follow up on the KPIs. Okay, if you think that through, the annual negotiation between health insurance companies and hospitals will probably be added by having somebody who also thinks of investments. That is true. From a financial point of view, these non-corresponding channels need to be overcome. I mean, you can put a lot of money into building infrastructure, photovoltaics, LED illumination, heat pumps, etc. This all needs to be thought completely differently to achieve the transformation of energy provision away from fossil fuels to renewables. But this is not included in remuneration or DIGs, etc. And this is completely uncoupled. Should be included, though, and with financial reporting, this will become, and sustainability reporting, this will become more transparent. It is helpful. It will help make headway here and will lead to a new focus within the management of hospitals and the boards of hospitals. Now, if I look at the issue of sustainability, it's not that this is being pushed because of the regulations, but if you're not sustainable now, the hospital will have disappeared tomorrow, because the topic of energy has, become so urgent that if you don't invest in solar panels or obscure things like windmills on the roof of the hospital, I mean, if you don't try to participate in that, you will lose out and will go bankrupt. LED, lighting, all of these things are important already. I think what's even more interesting, two of the aspects that you mentioned in the beginning, when it was said the population, people, citizens save energy. 1 or 2 degrees colder is nothing that anybody notices, but we can't do that in a hospital. You can't turn down the heating in the patients' rooms or in care homes. You can't do that. You can't tell people it's also quite comfortable in a 19-degree environment. I mean, you can do it, but it's not possible to uphold this on a legal point of view. And I mean, the Act on the Future of Hospitals, there are people who think about a new accounting center for the hospital, but with regard to sustainability, this is something that shouldn't be done at all, especially digitalization. I mean, digitalization is something that consumes so much more energy, and that's actually countering sustainability, or we should have experts do this. A super scaler should serve all hospitals by providing their accounting center. Yeah, you could also invest in your own servers. But let me come back to sustainability. We do have the challenge that if we want to be sustainable, big investments are necessary. That's what you mentioned more or less between the lines. And with the Act on the Future of Hospitals, whether everything is being done perfectly in this act is debatable, but a lot of money that went into the hospitals is being used. We want the care providers to also be sustainable, but no money is made available there. And I thought that was quite interesting in Denmark, the conditions. How does a retirement home look like? What are the accessories that are, or the equipment that is being used, the municipalities that equip people at home with digital devices so that telecare, remote care can be done, and how does it work, teaching, etc. I mean, this is also connected to sustainability, and it requires investments to make this possible in the first place. I just wanted to add that. Well, the term sustainability is not very clearly defined. ESG, environmental, social, governance, these are very broad-based topics, and it's not just what we just talked about. It's not just the energy efficiency of buildings. We will have to look at the whole picture. And even though we currently have quite low energy prices and the CO2 fees that aren't that high, but should be higher in order to take the environmental impact into consideration, but still it is not economically feasible if you have 20 years or so before an investment pays off. And as far as technology is concerned, investments are also estimated. You should put photovoltaics on roofs, and we did the analysis, we are doing it, but if we currently only have 1% of our roofs with PV, but it's only 1% of our energy need. And if we had all of our roofs covered, it would be 3%. So you always have to, put this into perspective. In the first two presentations, we've seen what the mega topics are, what the mega issues are: increase of efficiency, lack of skilled workers, etc., etc. And they're always connected to issues of sustainability. And this is the big task of, solving this correctly. And I would always be in favor of digitalization, process optimization, away from paper. Availability of data needs to be prioritized over saving energy. We cannot do both at the same time. It would be good if the computing centers could be done as efficiently as possible, server virtualization, water saving, etc., etc. And if you can't do that all by yourself, you would have to think of the cloud. But then the issue of data protection comes up: who owns the data, and.
Small note or thought about when we talk about sustainability, and I have huge respect for those who work with optimizing our energy, plastic resources, and a lot of things. But I was thinking of a project I participated in a municipality called Næstved in Denmark. It was called Kluge Kvadratmeter, where they at the municipality, they looked at do we actually need all the space we have. And I think in this regard, and the way that the thinking we would like to promote, also together with partners like Falk, is: do we actually need all the patients we have at the hospital, or actually how large a degree of the treatments we offer today in-house should and could be at home instead? And I think that's also a way of, in Denmark, when you talk about the new super hospitals and the scaling of this, we should turn it around, saying from the starting point, we should say that all treatments should be available at home or closer to the patients or the citizens, because they are citizens. And then say, okay, which ones of those can we not reasonably deliver at home?
In particular, this makes me really nervous because we probably all know the studies from Johns Hopkins. More than 20 years ago, they tried to find out how may a hospital work without beds and without patients. And there's no progress. So we are still talking about things that may occur to all of us every day, but we don't start to work on this.
Just very briefly, the Johns Hopkins studies from the 2000s. It's very worth reading, because many of the ideas that are being discussed here can be found there, scientifically backed and presented in a way that is understandable from a medical and economic point of view. Well, that's also something I presented here, the virtual hospital. And it is interesting, and I think that's important, because Denmark is pursuing this, as is Great Britain. Only those who are able or who want to be remotely treated are remotely treated. People who require considerable care, who need personal attention, personal care, will continue to receive that. Those who say, I don't want to be visited at home, I don't want to go to the hospital, have the possibility of receiving that virtual treatment. And this individual approach is very important. We also did the same thing in stoma care. We saw some need support, others need less, others need it longer. And then there are those who are so informed and educated that you only need to contact them once a year via telephone. I think this lawnmower principle is a problem, and digitalization can support us in reaching out on a more individual basis to the patients, pursuing more individual patient pathways, and also equal treatment, i.e., do we want to have more or less quality is not the issue. Everybody should receive the same level of quality. And if we talk about services, sure, but when we talk about healthcare or caregiving, medical, therapeutic services, everybody needs to be able to receive the maximum level of quality. And I think that was very, very interesting with the virtual hospital. It's not about everybody being at home, not receiving care, but being at home, receiving care to the extent they need it. Okay, by the way, if you have any questions in the audience, don't hold back. Questions or comments, feel free. If you could please introduce yourself very quickly, and if you could please use a microphone, otherwise there cannot be any translation because the interpreters cannot hear what you're saying.
Habe mich in letzter Zeit
I looked at new approaches regarding ethical issues. When we talk about population health, we can say that the interest of society trumps the interest of the individual. Now, if I look at the quality of services or the care given, that needs to be paid one way or the other. So from your expert point of view, also from the Danish point of view, I'd be interested in learning a patient who deliberately doesn't support his or her healing process. Should he or she receive the same level of care as those who help? I mean, somebody who continuously smokes costs more money in the interest of society as a whole. And I have a problem with the idea of equal treatment here. Somebody who is participating, who complies, who lives in a way that could be called in solidarity with society should receive more support. Well, to directly answer that, this is not what the principle of equal treatment means. I think the Danish approach is quite interesting here. During the, I once listened to a presentation in Oldenburg on this topic, and the question was, what if somebody who receives care at home and doesn't use the equipment made available to them because, I don't know, they don't like the way it looks, etc. So that would mean they no longer receive care. At the end of the day, it's my free decision, my free will. And the Danish are at the forefront of saying it is your responsibility to live in a healthy way, in a compliant way. I mean, you have to use the equipment, the devices, or not. I don't know if I've summarized this correctly, but the responsibility of receiving meaningful care also means to be compliant, or compliant isn't used anymore, but to participate, to help, to assist, and to also accept certain aesthetic infringements and use the automated lift or the stair lift or something like that.
Es ist wirklich eine sehr schwierige Frage. Ich glaube halt.
It's a very difficult question. You know, I always believe in the innate good of people, but I think Mr. Meyer also addressed this. Let's take Germany. Let's take Lower Saxony. There's a hospital in Bonn. On average, people live 10 years longer in Bonn than they do in Saxony-Anhalt. Nobody wants to acknowledge that. But we have to talk about socio-economic differences and how to address them. And when you say, should we support the chain smoker? The answer will probably be, he's going to die 10 years earlier anyway, so he already has to live through a tough life. And the second question you probably ask is going to be, what about the smoker? Well, that's the smoker, but what about a healthy lifestyle? I think it was you who said there is equality and equity, but there is also that wonderful image or that cartoon, this is the med. There's people are in line to get the medication, and here's the healthy lifestyle. Nobody's standing on line for that. But what is actually saving lives is changing your behavior. But nobody's willing to do that. And we try to illustrate that in a very interesting way already. At the time, at my old employer, we tried to develop programs for cardiology. So we were working on programs, we were coding an app. It started as a joke, pretty much. For instance, a blood pressure device. We all measured, we took our blood pressure and we realized, oh, we have regular blood pressure. We called it regular because nobody dared to say that more than 130 is high. Everybody pretended as if having blood pressure of over 130 would be normal. Well, I changed my life. I did less startup work, and suddenly I worked less, and suddenly I had a blood pressure of less than 120. So that does save lives, and it's pretty quick how you can turn your life around, and how can we promote that? So this leads to the question, how can we as a society take people on board? How can we promote population health? And I agree with you in that Danish model. I mean, everyone's responsible for his or her own health, but it's also important to tell people, or if people are healthier, then we can make headway for society as a whole. We don't need equality, but certain regions need more support than others to have that healthy lifestyle.
Completely agree. And I think my answer would be, because I know that the frank answer from us will be that, but if you don't contribute yourself, and that is my opinion, then you shouldn't get the help. But that is the very hard answer to that. And I don't mean that in that way, because I'm the old school in Denmark still, where I believe that we have in Danish it's called a samfundskontrakt. We have a contract with society, which goes both ways, so that we deliver to society, but we can also expect support when we need to. And that also means that we can also expect that if you look at the socio-economic, if you look at the structural system in Denmark, that we can also expect that society recognizes we don't have the same starting point. And we need different support along the way during our lives. And I'm an anthropologist, trained anthropologist, so I believe if there's someone who says, I don't want this, I'm not participating in this, and so forth, there's always a reason, there's always a rational reason for the individual. And if we, with my presentation in mind, really mean that we will take as our starting point the individual, the citizen, that should be the reason. The question is, why does this person not want to participate? We have an example with the 60% of the patients, the citizens that we sent back to the municipality of Lolland, they never, for rehabilitation, they never turn up. 60%. That's a really, really high number, and we don't know why. The only thing we know is that they will probably return to us again when their leg is so bad that we need to cut it off.
Und da auch nochmal zurückzufragen.
Let's get back to that original question. I think Dr. Meyer really pointed that out. He told us about the number of doctors that are going to retire, and in Germany, most of the hospitals will be affected by that. But if we talk about rural areas, there is no specialized doctor anymore. It takes people to get an hour to get to the hospital on average. you are at 14 minutes, and in Berlin you should get help within a couple of minutes, but there are certain areas that are so remote that you can't reach. There is no specialist doctor, so they don't get good care from a general practitioner either, if there's even one in the first place. So is it really up to them to should we really blame them for being born there, for being raised in that remote area? This is something we also have to address. Maybe we can set up these health kiosks, keeping in mind the American idea behind it. We should support that. Telemedicine, telemonitoring, virtual wards. We should support these kind of things. If I take a look at inpatient care, I would also have to re-examine care for people. Can't really call it bad or good. In the past, you used to have a fixed doctor in these wards, or that was allocated to a hospital, and that doctor was willing to go there. But now people have to organize drivers and have to be sent to a different hospital. It takes them a long time. It's a very sad situation. Let's talk about telemedicine. We also participate in municipal projects, which is about care in general. And every time before we start projects like that, we have to get municipalities and policymakers on the ground on board. And we have to convince them that it's a good idea. It's quite a difficult job. Currently, we're working on fostering the supply of care in rural areas, and we're doing that in the city of Stade right now, or the county of Stade. We talked to the mayor, and we're working with the mayor there because there aren't any doctor's offices anymore, and also, of course, no specialist doctors. Or maybe there's one GP that's 75 years old. But so we talked to the mayor and the social committee, and that committee said, okay, we would like to have a doctor on the ground. We don't like telemedicine. And that really leaves me, well, I'm really surprised, because it's not about an alternative offer. Either you take telemedicine or you have no care at all. That's what I'm trying to point out here. We have to communicate with citizens. Citizens need to know about the lack of care and what there is in their region, and what impact that will have on their social situation. We have to find a better way of communicating the advantages of that, which is very important. Thank you. I would like to add something. You talked about socio-economic conditions as well. Here in Berlin, for instance, you can take a look at the different districts, and according to your district, you know how good of a care you have and how long you're going to live. And in Munich, we worked on a project together with the Healthcare Association of Bavaria, and they took a look at the socioeconomic conditions. I don't know if you're familiar with that. It's actually a very good paper. It also contains the digitization. There's a follow-up project in Germany which is called SPECI, S-P-C-E. Here, physicians, socio-economists, nurses, and others, also ethic professionals got together, and they tried to take into consideration different perspectives, such as ethics and others, and how this could have an impact on healthcare now and in the future. So they developed quite impressive recommendations, and I was struck by that because it wasn't really self-evident. The UKE actually won the tender, and we have different clinics, hospitals, NGOs that are participating in that, and I think this will be part of the future. We should leave or go beyond our niche of the medical discussion. That's what I saw in Denmark. You are already taking that or the cross-discipline approach, and you go beyond that. And this is very different from Germany. Mr. Meyer, I have a question for you. But that's actually not planned, is it? Well, you talked about Berlin. I myself from the district of Neukölln, and we think we are entitled to certain things. I was born a guerrilla. So that's a very interesting question now. At least in Germany, there are certain regions that were abandoned. And now we have this new concept, and many consider it to be a death sentence. What about the level 1A hospitals, 1E hospitals? They offer integrated care across different sectors. 1I. Is that a good solution? Could that really turn things around for healthcare? Those so-called level 1E, 1I hospitals could be a lever and could really turn things around for the patient's journey. I'm going to give you my personal opinion on that. Of course, this is an opportunity. This way we would be able, since you're the guerrilla fighter or warrior, this would be a good way to improve things. But there's one thing I don't quite understand about this concept of the 1I hospitals. It has to be funded. And there is no funding mechanism. We don't have any hybrid ESGs or hybrid KPIs. That's still missing. And if we take the 1I clinics seriously, then we have to wonder whether we still need that double track specialist career for doctors that we still have in Germany. Well, in the past decades, we didn't really take that into account, and I'm quite worried that without eliminating this two-track career path for doctors, it might be very difficult for patients to decide who to approach or which doctor to attend, which doctor is going to tell me the right diagnosis for my disease. I think here we still have some work to do. And we should also work on something else. And Mrs. Phillips said that. Let's not forget that community leaders are also responsible for services of public interest. That's part of their contract. They are responsible for services of public interest. But you haven't really talked to the county leaders yet. So here we have to really involve those county commissioners in this discussion. Otherwise, they don't really know what to expect in the future. I would like to comment on that, and I would like to talk about these hospitals. Well, you should take into account those reservations that certain hospitals have. For instance, sometimes this really leads to concerns that this will be short-term care of the future because institutions won't have any space anymore. Because let's imagine you have patients coming from specialist clinics to a different clinic. If we want to have a more interdisciplinary approach here and have a steering effect, we need very independent jobs here. And for that, we need the right kind of profile and we need the right kind of accountant or the right kind of invoicing, so to speak, so that hospitals can live up to their true function. And I would like to add something. The head of the Reform Commission is, I know him quite well, and he's very grateful for every idea that the Commission might not have considered yet. When you write an email to that person who works for the Ministry of Health, you will get a feedback note. You will know either he's going to process it, he's going to use it or not use it, or put it aside. So you will get feedback on your suggestions. So let me just encourage you, make use of that. Approach this head of the committee. These are open-minded people who are, of course, shaped by university clinics, I know, but these people want to work on good solutions. They don't want to work on quick fixes. They rather want to work on long-term sustainable solutions. I think that's good. I think we're done now.
Gibt es noch?
Are there any comments or questions? If you don't have any comments, I would like to ask the last stupid concluding question of the day. So we talked a lot about innovation. We talked about life expectancy. We talked about human versus machines. And also during the lunch break, we talked about different family types and what they can do in terms of care. And we also had many different debates. But they are based on this system intrinsic logic. So my last question is the following one. Are we, as a society, as industry as a whole, are we actually guiding the development? Are we guiding it enough in the healthcare sector? Or are we being too passive? Are we reacting? Are we only reacting to the changes? Just a brief answer that would make me very happy. Well, the first stupid answer is always 42. And the true answer is that we are acting. Innovation, true innovation is always regulatory innovation. If you change regulations, we behave differently. Hence, should we start with regulations, reforms? Are we brave enough to do certain things? If it's painful or not, if it's right or not, we need more regulatory action. I don't have the answer to that, but regulatory policy in the hospital sector in Germany always means that you are dismissing certain things. I would like to give you my perspective on behalf of the university clinic. We know that there is a discourse or there is a debate, and this leads to reimagining things. And well, we need impetus for controlling in order to act and react. And of course, it's difficult to put these topics aside that are imminent of the system. I believe in order to be able to control and steer things, we need an architecture committee that will go beyond the current legislative term and that is going to deal with the current reshaping of our health system, redesigning it. And only this way we will have that concerted effort of creating the right prerequisites and making the right decisions. So rural areas, or municipalities, state government, national government, and in order to do that, we need that committee that is going to develop a new healthcare system that goes beyond the current legislative term? My answer is no way.
Vielen Dank. Ich finde,
Thank you, thank you, thank you, thank you. I think let's give it up, a round of applause.
und natürlich auch ein sehr
And thank you to Jan Kanne, who came all the way to Germany prior to the Fehmarnbelt Tunnel. It will open soon. And thank you also to Mr. Meyer.
und von
So all that's left for me to say is, on behalf of the embassy, thank you very much to all of you for coming. Thank you for breathing so much life into this day and for ensuring that we continue to look at this very, very important topic and that we can have an exchange on opinions nationally and internationally. And thank you very much to our health team, Hein Schierbeck, Ingela Elliwell, and Olaf Meyer. They ask you if you have any ideas for workshop, alliances, exchanges, field trips, anything, or if you have a stroke of genius, do not hesitate, contact them, contact our health team, and make sure that we can continue this productive dialogue across the border. So this is how the day ends. Thank you very much for coming, and we can now enjoy Danish Hygge and Deutsche Gemütlichkeit with a cup of coffee. Thank you.